We are going to talk about comorbid disorders in this chapter. So chapter 9 PowerPoints are posted to Canvas right now. And then, of course, I hope you've done the reading at this point, or maybe you're reading along as I'm talking. So we're talking about comorbid disorders. And comorbidity is comorbid disorders is essentially when two mental health issues or three or four mental health issues occur at the same time. So what that looks like is it could be major depressive disorder and opioid use disorder, or bipolar disorder and alcohol use disorder, or alcohol use disorder and an opioid use disorder. It's just multiple mental health issues that occur at the same time in an individual. We no longer use the term dual diagnosis, nor do we use the term co-occurring. We now use comorbid and comorbidity. That's important that you use the proper language. However, as a field, and you'll even notice in your textbook as a field, we sort of have a hard time phasing out language. But for your information, we do not use dual diagnosis or co-occurring. We use comorbid. The other sort of substantial change in the DSM-5 when it talks about diagnosing and substance use disorders is we drop the terms abuse and dependence. And the reason why, and just kind of think about this as you say those words, abuse. So abuse is something that it sounds as though the individual is actively engaging in doing this. So essentially, it's a pretty negative or pejorative term. Individuals are choosing to use substances to the point that they cause them this much negative consequences. That's the that's the sort of underpinning of an addiction is, they're engaging in these negative behaviors despite these negative consequences. The concept of choice, as we tend to think about it, is not present. So when we think about abuse, it's this really active process that one may engage in, and that's just not clear or accurate when we talk about substance use disorders. When we think about the term dependence, we have to be really careful, and the reason why it was dropped is because not all substances or addictive use disorders have a dependence associated with them. As you guys learned when we talked about substances, not all have withdrawal and not all have dependence. And so just because you've developed, and likewise, just because you've developed a dependence to something does not mean you have an addictive use disorder. Let's use this as an example. If you happen to have a big major surgery and you happen to need pretty substantial opioids for recovery related to this major surgery, you will more than likely develop a tolerance and a dependence. That does not mean you will develop a substance use disorder. It just means that you may need more of the substances to alleviate the pain associated with the surgery. Again, we're talking about tolerance there. And the dependence means you have now physiologically developed a need to have this substance, which means you are going to go through withdrawals, which means you need to be weaned off of this substance. That does not mean you have an addictive use disorder. I hope everyone understands the difference there. So just needing a substance physiologically does not equate to an addictive use disorder. Of course, there are connections and correlations and associated with this, but I think in the sort of the basic understanding is that these two things do not equal each other. Dependence and an addiction are not the same. Just because you may actively partake in something that you're engaging in a little bit too much does not necessarily mean that that you're abusing something, or it doesn't mean that abuse is necessarily again associated with an addictive use disorder. I hope that's really clear because that's a really important part of this chapter. And I hope I didn't provide too many examples that got a little confusing. So Sorry, I went the wrong way. What we do know is, unfortunately, individuals who struggle with both an addictive use disorder and some other mental health issue, they do have poorer outcomes. There's less opportunity for treatment. It costs more money. It's difficult to find treatment centers sometimes that effectively and appropriately handle both the mental health issue and the substance use disorder. And as you found in the professional issues section early on, not all addictive use disorder professionals are equipped or trained in handling the mental health component. So here's the dilemma. Here's the dilemma. When an individual seeks treatment for an addictive use disorder, if they are being treated by someone who is not skilled, trained, or qualified to handle a mental health issue, what are we doing? How are we addressing all parts of this human being? How are we providing holistic counseling? And are we missing a huge piece of that person and a huge piece of why this individual engages in this relationship with their substance to the point that it is an addictive use disorder? Have we missed that? The answer is yes, and we're going to continue to sort of talk about that. So these numbers are pretty interesting. Sorry, I'm flipping through my notes here. They're pretty high. The numbers are pretty high and they're pretty substantial. Just put it simply, having a client who only has an addictive use disorder is the exception, not the rule. What does that mean? You will more than likely experience or encounter or work with individuals who have both an addictive use disorder and another mental health issue. You can see that, again, sort of the stats here: substance use disorder and suicides. If you're 6 times more likely to commit suicide if you have both a substance use disorder and a mental health disorder than the average population. 6 times. That's really interesting, and that's pretty substantial numbers. I want to jump back really quickly here to this thing. I forgot to kind of mention something. When we talked about folks being equipped and trained to handle both mental health issues and substance use disorders, your book talks about confrontation. And this last bullet point here, mental health and substance abuse professionals disagree on some basic ideas. So your book goes into the idea of confrontation. And it talks about how it is ineffective as a treatment form, and it is ineffective in dealing with both addictive use disorders and mental health issues. And we found this out through research and just doing our due diligence as counselors and therapists and researchers that look at this approach. What used to happen in traditional treatment approaches is that you would go to AA treatment centers or 12-step treatment centers, and there would be this sort of breaking you down to building you back up philosophy. So there was confrontation, there was criticism, there was negativity. It was very volatile, a form of treatment. We know that that's not the same, or that is not effective anymore. And so confrontation is very different than challenging. We talk to you about your ability to challenge your clients, but confrontation in this context is very different. So make a note of that. I'm not going to go into the assessments. You've got a lot of opportunity for assessments, but definitely read. There certainly, as we talked about in the last couple of chapters, assessments that look at both mental health issues and addictive use disorders. This is the important part here, and we're going to spend a little bit of time on this on this slide. So the use of an addictive substance can initiate, exacerbate, mask, or mimic a psychiatric problem. So what that means is when you're looking at an individual who may have a mental health issue and you don't consider whether or not a substance use disorder or substances are playing a role, then you're only looking at one piece of the pie here. then you're going to inaccurately diagnose or provide a diagnostic impression of this mental health issue that are really behavior, symptoms, and whatnot associated with the substance. So it could be an individual is withdrawing off the substance, and then you see this cluster of psychiatric symptoms, and so you inaccurately assume that it's a mental health issue when really it's a byproduct, if you will, or an effect of the substances the individual is on. It could also be a result of withdrawal. Many times in emergency rooms, and particularly in prison populations or jail populations or correctional facilities, many times individuals are inaccurately diagnosed with a mental health issue because of the substances that they were on or were taking prior to being admitted into these facilities. So particularly like maybe bipolar disorder is oftentimes diagnosed, and then people are put on medication, but the clinician or the physician or whoever it was did not do their due diligence to see which came first. Was there a psychiatric condition that is separate from the mental health issue, or is this just one mental health issue, or is this one addictive use disorder? I hope this is making sense. And then, so what do we do about this? So it's really important for us and the people that we're working with, the other clinicians, the psychiatrists, the practitioners that we're working with. It's very important for us to figure out what the individual looks like when substances are removed and have been removed for quite some time. So what we would ideally like to do is remove the substances from the individual, or have the individual be removed from substances, be not taking substances for quite some time, and then see if a mental health issue surfaces, if the mental health issue diminishes, if the mental health issue gets worse, or what. Or maybe a combination of all of those things. But we cannot just sort of flippantly or recklessly start assigning diagnoses when we haven't figured out which is the behaviors associated with the substance and what are the behaviors and symptoms associated with a mental health issue. I know this is kind of a lot to grasp, but it is incredibly important that we figure out what is clearly going on with the individual. As we just talked about according to the numbers, most of the folks that you encounter with an addictive use disorder will also have a mental health issue. We need to clearly see what the individual looks like without substances to determine what mental health issue it is. And then again, that whole chicken or an egg conversation, which came first, the substance use disorder or the mental health issue. Mental health issue could be affecting, exacerbating, mimicking substance use disorders, or making engaging in substance use disorders more prevalent. And then substance use disorders can mimic, exacerbate, and initiate or mask mental health issues. I hope that's clear. Let's see, where do I want to go next? So looking at this, as with anything, it's important to consider the culture and the ethnicity and race, and to consider the individual prior to making a diagnosis and prior to figuring out what's going on with them, and be aware of your own bias, and be aware of how these types of behaviors that you may be seeing in your client are explained or identified in the individual's culture. Treatment and care needs. What's the takeaway here? We need to make sure that we are referring clients to treatment centers that address both mental health and psychiatric conditions. We're going to talk a lot about the deficit of our traditional approach when we talk about 12-step and AA treatment programs in a couple of weeks, because we're not doing that very well right now. I think that's it for this chapter.